US and ERCP guided combined approach as a rescue treatment in type 4 block. 45-year-old male had history of progressive jaundice, pruritus and weight loss in 2 months. CT showed mass lesion with undefined margin in hilar region. Mass was extending both right and left side. MRCP showed type 4 block with complete separation of IHBR in left side and also separation of right anterior and posterior ducts. He underwent PTVD in right posterior duct in the hospital, but his bilirubin was not improved. Even he developed cholangitis. He also complained of persistent pain at drain side. Then patient referred to us for further management. US FNB was done from the mass which showed adenocarcinoma. Here we can see left lobe is quite atrophic. Then US from D1 where we can see a PTVD catheter in right posterior duct and quite dilated right anterior duct. So his final diagnosis cholangiocarcinoma inoperable type 4 block, PTVD catheter in right posterior duct and cholangitis. So what are the treatment options here? We need drainage to improve cholangitis and for chemotherapy. No meaning of drainage of left lobe because left lobe was atrophic and complete separation of duct. Caudate lobe is draining in right anterior duct. So if we drain right anterior and posterior duct, we can able to drain maximum part of the liver. So drainage option here first PTVD. Patient did not want PTVD. He was afraid due to previous PTVD related treatment. Second option is ERCP guided 2 cents placement in right anterior and posterior duct. In this diagram we can see non-formation of the primary confluence and also separation of right anterior and posterior hepatic duct, also complete separation of the left ductal system. So my plan was place SAMS in right anterior duct first, then right posterior duct. Here PTVD catheter seen which is coming from the right posterior duct till ampulla. During ERCP wire gone in duct which appeared likely right anterior duct and while was not coming during the aspiration and limited cholangiogram did not showed any dilatation, so doubt were arise that I was not in right duct. So another hydrophilic wire tried to put in right duct after placing first wire but could not place in right duct. So how can I confirm whether this wire is in right anterior duct? For that I removed only duodenoscope and wire was still kept in duct just like Rendu procedure. Then introduce ureoscope till D1 to see whether this wire is in right anterior duct or not. So this is the right anterior duct, no wire seen in this duct. The duct is punctured with needle and wire placed on fluoro. We can see US and ERCP guided wire both were in different duct, means ERCP wire was not in right duct. Then finally I decided to do US hepaticoduodenostomy. I managed to take right anterior duct near the entry point of the needle and distance was only 2 cm. Then duct is punctured with 19G FN needle, a vial aspirated and contrast injected and position confirmed. Then 035 Visiglide wire placed in the IHBR, then 6 French cystotomy introduced over the wire. Then I tried to place 10 cm partially covered stand. So this red arrow showed total uncovered part of the stand and small red arrow showed uncovered part outside the HBR. So there was chances of bile leak if I put this stand. So I have tried to place 8 cm in place of 10 cm uncovered stand which has 3.5 cm uncovered part. But still some uncovered part is outside the HBR. I did not have any partial uncovered stand smaller than 8 cm, so I left only one option to place 6 cm fully covered stand. Then 7 French 7 cm double pectoral stand placed through the SAMS to avoid migration. The next plan was placement of SAMS in right posterior duct. So 10 cm uncovered stand placed in right posterior duct. Here we can see hepaticoduodenostomy covered stem in right anterior and ERCP uncovered SAMS in right posterior duct. After 2 days, HDS stent had slight internal migration. Loop and clip stent fixation technique was published from our center to avoid migration of esophageal SAMS. Same concept applied here. Then first 2 clip applied with the stent and loop. Then few clip applied between the loop and normal mucus. Endoscopy after 1 week did not show any stent migration.